The topic is inflammatory bowel disease. Disease, that means it's a pathology. Pathology of what? It is the pathology of your bowel, that is your intestine. It's the pathology of your intestine. What type of pathology of your intestine? It is an inflammatory pathology. That means it is associated with inflammation, plus there is also ulceration. So inflammatory bowel disease is a disease or pathology of your bowel or intestine that is associated with inflammation and ulceration. Again, inflammatory bowel disease, disease of your bowel, pathology of your intestine that has inflammation and ulceration. Under inflammatory bowel disease, we are going to learn about two diseases: Crohn's disease and ulcerative colitis. So we are going to learn about Crohn's disease and ulcerative colitis. Both Crohn's disease and ulcerative colitis, they are inflammatory bowel disease. That's why in order to make your life easier, what I'm gonna do is teach you both the diseases in a comparative fashion under similar headings. That will make mogging up points easier. But we know very well, mogging up several points, point after point, is really tough and tedious. So what I'm gonna do is, after having taught you both the diseases in comparative fashion, I'm gonna make a single diagram for both of them, and that single diagram is going to inculcate all the points that I'm going to teach you right now, and that will help you visualize or memorize very easy. Okay, with all that guff, let's begin the comparative study between the two inflammatory bowel disease. Those are the Crohn's disease and ulcerative colitis. Are we ready? All right. First, we will look at the gross, then we will look at the microscopy. First, gross of both the diseases. In Crohn's disease lesion, we have skip lesion. That is, a part of the intestine has lesion, then there is normal part of the intestine. Again, there is lesion, again normal part of the intestine, again lesion, and then normal part of the intestine. That means the lesion is skipping over normal part of the intestine. The lesion, it is not continuous. There is lesion and then normal, lesion and then normal. See, so here's the lesion and then normal intestine. Here's the lesion and then normal intestine. Here's the lesion again. Here's the normal intestine and then the lesion. Again, normal intestine and then the lesion. As you can see, the lesion, it is not continuous. It is skipping over a part of normal intestine. So there are skip lesions in Crohn's disease. Next, ulcerative colitis lesion. You can see that the lesion is continuous. It is continuously spreading. There is no normal part within the lesion. The complete involved part has the pathology. There is no normal and then lesion, normal and then lesion. Continuous. The lesion is continuous. Second, most common site. In Crohn's disease, the most common site of involvement are, the most common site of lesion are the terminal ileum, the ileocecal junction, and the cecum. Again, the terminal ileum, the ileocecal junction, and the cecum. In ulcerative colitis, the rectum is always involved. The rectum is always involved, and it is from rectum that the lesion starts to spread backward. All right. Next, spread. So in Crohn's disease, what did I say? The most common site of lesion are your terminal ileum, the ileocecal junction, and the cecum. Let's say the lesion begins at the ileocecal junction. Now from the ileocecal junction, the lesion spreads both forward and backward. That is both antegrade and retrograde spread. Antegrade from ileocecal junction, it's going to involve the large intestine, the colon. It is going to involve the large intestine. And retrograde, it is involving the small intestine. It is involving the small intestine. From small intestine, it can spread into stomach. and then it can go back into esophagus. So retrogradely from backward, by going backward from ileocecal junction, it can involve the ileum and then the stomach and then the esophagus, and it can involve the complete gastrointestinal tract. Okay. In ulcerative colitis, what did I say? I said that in ulcerative colitis, the lesion begins at rectum, and from the rectum, the lesion continuously, without skipping any region, spreads backward. See, it's going backward or retrograde fashion. Now, depending on how much part of the intestine is involved, it's of different type. So it begins at the rectum, we know that. And if only rectum is affected, that is proctitis. The lesion, it is within the rectum only, that is proctitis. Procto refers to rectum. If it involves the rectum and goes backward and spreads into the sigmoid colon as well, it is proctosigmoiditis. Procto referring to rectum and sigmoid referring to the sigmoid colon. If it spreads further, involving rectum, sigmoid colon and descending colon, this is distal colitis because the complete distal part of the large intestine is involved. If it involves majority of the large intestine, that is the rectum, the sigmoid colon, the descending colon, as well as the transverse colon, there is extensive involvement. This is called extensive colitis. If it involves the complete large intestine, rectum, sigmoid colon, descending colon, transverse colon, as well as ascending colon, there is complete colonic involvement. So pancolitis. Sometimes pancolitis can worsen and exaggerate and enter into the terminal part of the ileum. Terminal part of the ileum. Since the spread takes place backward and this backward spread enters into the terminal ileum, this is called backwas ileitis. Backwas ileitis. Alright, till now what have we seen? Crohn's disease, ulcerative colitis. In Crohn's disease, lesion, there are skip lesions. Lesion, normal. Lesion, normal. Ulcerative colitis, continuous lesion. There is no normal within the lesion. The lesion spreads continuously. In Crohn's disease, the most common site of lesions are the terminal ileum, ileocecal junction, and cecum. In ulcerative colitis, the most common site of lesion is the rectum. Not most common site, it always involves the rectum, and from rectum the spreading begins. Okay, in Crohn's disease, the spread is, let's say it begins at the ileocecal junction, then it spreads both forward in antegrade fashion and involves the large intestine, and backward in retrograde fashion and involves the small intestine. It may even involve the stomach, esophagus, and the complete gastrointestinal tract by going backward. In ulcerative colitis, it begins at rectum and it can only go backward. It goes backward continuously without leaving a site, without skipping a site. So continuous lesion goes backward. Backward, if only colon is involved, that is proctitis. If colon and sigmoid colon is, if only rectum is involved, that's proctitis. If rectum and sigmoid colon is involved, that's proctosigmoiditis. If complete colon is involved, that's pancolitis. If from colon it enters the terminal ileum, that is backwas ileitis, because it is coming backward into the terminal ileum. So backwas ileitis. Okay, I hope this much has been mocked up in your brain. Okay, let's move on. So in ulcerative colitis, let's take one of them, proctosigmoiditis. You can see that the lesion, it spreads backward. So there is area of lesion and there is abrupt demarcation between lesion and normal mucosa. This much mucosa has lesion and this much is normal. So there is abrupt change from lesion to normal. So if I cut this much portion out, this is what it looks like in the cadaver. This is the lesion and this is normal, and there is abrupt demarcation between lesion and normal. In pancolitis, it is the complete colon that is involved. So if I take out this colon, this is what it looks like. The complete colon is involved, pancolitis. Okay, let's move on. Next, differentiating under the basis of ulcer. First, Crohn's disease. The very first lesion in Crohn's disease is aphthous ulcer. Aphthous ulcer. These aphthous ulcer, they grow and spread and connect with one another in snake-like pattern, which is now called serpentine ulcer. So these snake-like pattern forming ulcers are called serpentine ulcer. In between these serpentine ulcer, there is mucosa that is not involved. Bro, you know what ulcer is, right? You know ulcer, right? Ulcer is nothing but a breach in mucosa that can involve submucosa and may even perforate even inside, involving muscularis and creating complete perforation inside to outside. That's ulcer. Now, there are snake-like ulcer throughout, and in between these snake-like ulcer, there is mucosa that is not involved, that is spared. These spared mucosa, they swell up, and the spared swollen up mucosa along with serpentine ulcer gives cobblestone appearance. So these stones that you see, they look like the swollen mucosa, and in between them there is serpentine ulcer. Okay, here's the endoscopy. All these swollen thing that you see, these are the mucosa that is spared, the mucosa that is uninvolved, and in between them you have the serpentine ulcer. Okay. In ulcerative colitis, after ulcer, there are parts of mucosa that are regenerating, and these regenerating mucosa, they look like polyp. So these are the regenerating mucosa that look like polyp. However, they are not true polyp, so they are referred to as pseudo polyp. So these are the regenerating mucosa that give a polyp-like appearance. Some of these pseudo polyp, they grow and fuse with one another, forming breaches. So you can see right here, a breach 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 here. These breaches, they are connecting the pseudo polyps together. Okay. Next, Crohn's disease. We were talking about ulcer. In Crohn's disease, we have deep ulcer. Remember, in Crohn's disease, we have deep ulcer. Ulcer, normally, it involves mucosa. However, in case of Crohn's disease, it grows deeper into submucosa and even involves muscularis layer. See here, this is the Crohn's disease, lumen of the Crohn's disease, and this is the wall of the intestine with Crohn's disease. There is ulceration throughout mucosa, ulceration throughout submucosa, and even the muscular part is involved. And these deep ulcers that you see now, these are referred to as fissures. So there are deep ulcers referred to as fissures. Sometimes these ulcers grow so deep that they perforate through the whole wall. As a result, the cavity inside communicates with cavity outside, and this pathologic connection between two cavities is known as fistula. See, there is perforation in the wall of the intestine right here, creating fistula. So there are, in Crohn's disease, deep ulcers, which are referred to as fissures, that can grow deeper and create perforation, which results in fistula. Okay. In ulcerative colitis, however, there are shallow ulcers. That is, only mucosa or submucosa is involved. It does not perforate. The muscular layer. So there are no fissures. If there are no fissures, how can there be fistulas? So there are no fistulas. See, you can see right here as well. So there are these superficial ulcers in ulcerative colitis. In between them, there are these regenerating mucosa that give off polyp-like structure referred to as pseudopolyp. So these are pseudopolyp. Alright, once more, let's revise the ulcer of both of them. First, Crohn's disease. The very first lesion that you see in the wall of the intestine of Crohn's disease is aphthous ulcer. These aphthous ulcer, they grow and connect with one another in snake-like pattern. This is serpentine ulcer. In between these serpentine ulcer, there are parts of mucosa that have been left or spared, that is not involved. These mucosa that has been spared, they swell up, and then these swollen up spared mucosa along with serpentine ulcer give cobblestone appearance. The ulcer in Crohn's disease is deep or superficial. Which one? It is deep. These deep ulcer, they not just involve mucosa, not just submucosa, but also muscular layer, creating deep ulcers referred to as fissures. Sometimes these fissures grow so much that they create perforations in the wall of the intestine. As a result, the cavity inside the intestine communicates with cavity outside. This pathologic communication between two cavities is referred to as fistula. So there is fistula as well. In ulcerative colitis, there are deep or superficial ulcer. There are superficial ulcer. That means it does not involve the muscular layer. In between these superficial ulcer, there are regenerating mucosa that look like polyp but are not actually polyp, so-called pseudopolyp. These pseudopolyp, they grow and communicate with one another with the help of breezes. All right. In the next topic, you will be learning about intestinal polyps. Under there, you have neoplastic and non-neoplastic intestinal polyp. And under non-neoplastic intestinal polyp, you have the inflammatory non-neoplastic intestinal polyp. And the example of that is pseudopolyp, just for your knowledge. Okay. Next, the wall of the intestine. In Crohn's disease, there is transmural involvement. That means the complete thickness of the wall of the intestine is involved. Involved how? There is inflammation through the complete thickness of the wall. As a result, there is a repair and fibrosis through the complete thickness of the wall. See, this is the wall of the intestine with Crohn's disease. The complete thickness of the wall, goes through fibrosis. It goes through fibrosis. As a result, the wall becomes thick. The wall is thick, but the lumen is narrow. And this abnormal narrowing of the lumen is referred to as, in medicine, strictures. So there are strictures. This is how Crohn's disease has thick wall with narrow lumen or strictures due to transmural involvement, transmural fibrosis. Now, normally, this is your intestine. One of the borders of the intestine is the mesenteric border, and to this mesenteric border, the mesentery of the intestine is attached. On this mesentery, you have lots of fat. This is what normally we have. In case of Crohn's disease, as I said earlier, there is transmural involvement. That is, there is fibrosis throughout the complete thickness. That means outside also there is fibrosis now. So there is injury and fibrosis outside the intestine as well. What happens is that the fat present within the mesentery, it sticks on these fibrosis places, the places with fibrosis. At these injurious places, they stick and they spread over throughout the intestine. They creep over the intestine, and this is referred to as creeping fat. So this is creeping fat. Again, normally here's your intestine, and to the mesenteric border of the intestine, the mesentery is attached and the mesentery has fat. In Crohn's disease, since the outer wall of the intestine has gone through fibrosis, ulceration, injury, what happens is that the fat, it creeps over the outer surface of the intestine and attaches to these places and then creeps over it, called creeping fat. Covers the whole intestine from outside. Next, ulcerative colitis. In ulcerative colitis, there is no transmural involvement. As a result, there is no stricture. As a result, there is no creeping fat. But what you need to remember is that there is loss of hostrations. In ulcerative colitis, there is loss of hostration. So the feature, number one, the presence of stricture in Crohn's disease, and number two, the loss of hostration in ulcerative colitis. Both of them are appreciable under radiography. So what we did was we took a barium study of the intestine with Crohn's disease and ulcerative colitis, and saw the X-ray behind it. So this is what it looks like. First, the Crohn's disease. You can see right here, these feathery intestine. That is your jejunum. The smooth intestine, on the other hand, that's your ileum. At the end, the ileum has become very thin, right? This is the terminal ileum. And then terminal ileum, it ends in this funnel-shaped structure called the cecum. Okay. Now use your logic. In Crohn's disease, which part is most commonly affected? Terminal ileum. Second thing, in Crohn's disease, what happens? The wall becomes thin and the lumen becomes narrow. That is, there is stricture, narrow lumen, stricture. So if there is barium study, what is appreciated? Wall or the lumen? Obviously, the lumen is appreciated under X-ray. Under X-ray, what we are looking at all of this is the lumen of the intestine. Since there is thinning of the lumen, stricture, so stricture is present as well under barium study in the form of a string, dhago, string, and this is string sign. So string sign under barium study X-ray due to the presence of stricture in the terminal ileum as a result of Crohn's disease. Second, ulcerative colitis. In ulcerative colitis, the end result is loss of hostration. So can you see the loss of hostration? See, it begins at the rectum, then it spreads to the sigmoid colon, then the descending colon, then the transverse colon. Throughout this much, you can see that there is loss of hostration, and that is why it gives lead pipe appearance. It looks like a lead pipe due to loss of hostration. Okay, now I'm gonna make two separate diagrams for the two separate diseases, Crohn's disease and ulcerative colitis. And with the help of this diagram, I will be incorporating all the points that I have taught till now. Starting off with Crohn's disease. So what I'm gonna do is ask you a question and then answer that question with the help of the diagram. Okay, Crohn's disease. First question. What is the most common site where the lesion is present in Crohn's disease? Terminal ileum, ileocecal junction, and cecum. So let's draw that. Terminal ileum, the ileocecal junction, and cecum. Okay. Next question. What type of lesion do we get to see? Skip lesion. That is, there is a part of the intestine that has the lesion and then a part of the intestine that does not. Again, a part of the intestine that has the lesion and then a part of the intestine that is normal. So let's say this much part has the lesion, the terminal part, okay? So here it is. This is the lesion. What kind of lesion do we have? We have skip lesion. That means if this much part has lesion, this is the uninvolved part. So that's normal. Third question. What kind of spread is seen? So the spread is both retrograde and antegrade. That means if lesion is present right here, it will spread forward throughout the large intestine as well as backward throughout the small intestine and eventually into stomach and esophagus, involving the complete GI tract. Okay. Fourth question. What is the morphology of ulcer that is seen? The very first ulcer that you get to see are the aphthous ulcer. So these are the first lesions of Crohn's disease, the aphthous ulcer. These aphthous ulcer, they grow and connect with one another in snake-like pattern, referred to as serpentine ulcer. So these ulcers, they are referred to as serpentine ulcer. Now in between these serpentine ulcer, what can you see? You can see areas that are not involved or mucosa that is not involved. These mucosa that are not involved, they swell up. And these swollen, uninvolved mucosa along with the serpentine ulcer give off cobblestone appearance. So let's write that. We have our serpentine ulcer, and then we have the swollen mucosa, the swollen spared mucosa, and both together give off the cobblestone appearance. Okay. Now, another thing about ulcer. Is it deep or superficial in case of Crohn's disease? it is deep. So ulcer is deep. That is, it involves mucosa, submucosa, as well as the muscular layer. These deep ulcers involving the muscular layer as well are referred to as fissures. These fissures, they grow deeper and convert into fistula. So let's make them. There's fissure and then there's your fistula. Fistula. Fissures and fistula. Okay. Next question. Also done. Next is wall. What kind of involvement is there in the wall? There is transmural involvement. That is complete thickness of the wall of the intestine where the lesion is seen is involved. There is fibrosis throughout the complete thickness. As a result, the wall is thick. The wall is thick. There's thick wall. And the lumen is thin. This thin lumen is referred to as stricture. So we get to see thick wall and thin lumen. The thin lumen is referred to as stricture. Due to transmural involvement, fibrosis throughout the thickness of the wall takes place. That means there is ulcer and fibrosis outside wall, in the outer wall as well. As a result, the fat from the mesentery, it completely covers the intestine as it gets attached to the ulcer and fibrosis present on the outer wall. And this fat is referred to as the creeping fat. The creeping fat. And yeah, that's pretty much it for Crohn's disease. Next diagram for ulcerative colitis. Ulcerative colitis. Same questions. First, which is the most common site of lesion in ulcerative colitis? The rectum is always involved. The rectum is always involved. So let's draw the rectum. There's the rectum. Okay. Second, what kind of lesion is present here? Continuous lesion is present here. That is, it starts from the rectum and then spreads continuously. What is the spread? It spreads the retrograde fashion, that is backward. It spreads continuously. Let's say this is an example of proctosigmoiditis. That is, there is inflammation of procto referring to rectum and the sigmoid column. Rectum and the sigmoid column. So I'm gonna take a piece of the wall of the sigmoid column out to show you what is going on inside. Okay. There you go. There we 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 go. Join the two together. Okay. So now we can see what is happening inside the colon itself. What kind of lesion is present? We have continuous lesion which starts at the rectum and spreads retrograde fashion. Retrograde. Okay. Next question. Something about ulcer. What type of ulcer do we have here? We have superficial ulcer. That is, it is only the mucosa and submucosa that is involved. The muscular layer is not breached. There is no breach in the muscular layer. So there are superficial ulcer. Then there are parts of mucosa that is regenerating. These regenerating parts of mucosa, they appear as polyps. And they are referred to as pseudopolyps. Some of these pseudopolyps, what happens to them? They connect with one another with the help of bridges. But first let's fill the whole thing up because it is continuous, so you can't leave a part in the middle. I mean, if you left it, it would be skipped. You can't skip a part in the middle. And then let's draw some bridges here and there. Okay. There is first superficial ulcer. In between these superficial ulcer, there are regenerating mucosa that appear as polyp but are not true polyps, so pseudopolyp. These pseudopolyp, They grow and connect with one another with the help of bridges. Now, is the ulcer deep or superficial? I have already said it. It's superficial. That means, can you see fistulas and fissures? No, absolutely not. There are no fissures. There are no fistula. Next, wall. Is there transmural involvement? No, transmural involvement is not present. That means there is no creeping fat. That means there is no structure because the wall does not become thick and the lumen does not become thin. But what is present there is loss of hostration. Loss of hostration. There is loss of hostration. Wall also done. Well, that's the diagram that you need to draw in your exam. With that, we are done with the gross. Now let's compare the microscopy of both of them. Crohn's disease, ulcerative colitis. In Crohn's disease, I said that there are ulcers. What type of ulcers? Deep ulcers. And these deep ulcers are referred to as fissures. So in microscopy, you can see fissures. Simple. There is mucosa and then there is deep ulcer involving muscular layer as well. Mucosa, breach in mucosa, submucosa and muscular layer. These are referred to as fissures. We have deep fissures. Second thing I said in Crohn's disease is that there is transmural involvement. Transmural involvement, that is the complete thickness is involved. Mucosa, submucosa, muscularis. What kind of involvement? First, inflammation is throughout, then fibrosis is throughout. So you can see inflammatory cell throughout the wall, throughout the thickness of the wall. So these are the inflammatory cells throughout the thickness of the wall. Even in muscular layer, you can see the inflammatory cells. And third, the distinguishing feature or the typical feature of Crohn's disease is the presence of non-caseating granuloma. There is non-caseating granuloma. Ulcerative colitis. In ulcerative colitis, I said that the ulcer, they are superficial. So in microscopy also you can see superficial ulcers. See, there is mucosa, and then a breach in mucosa. Is the breach in mucosa deep or superficial? It's superficial. So there is superficial ulceration. Second thing I said that in ulcerative colitis, there is no transmural involvement. Okay, that means it is not the complete thickness of the wall that shows inflammation. So you can see inflammatory cell because it is an inflammatory disease, but not in muscular layer. Unlike Crohn's disease, in muscular layer also there are inflammatory cell, but in ulcerative colitis, inflammatory cell are not in muscular layer. A typical feature of ulcerative colitis is the presence of crypt abscess. What is crypt abscess? Abscess is nothing but localized pus. If the pus is localized in the crypt of the intestine, that is crypt abscess. Simple. Again, three things: ulcer, wall, and the typical feature. In Crohn's disease, there are deep ulcers referred to as fissures. There is transmural involvement. So in complete thickness, there are inflammatory cell. Typical feature, presence of non-caseating granuloma in ulcerative colitis. The ulcer, they are superficial. So there is superficial ulceration. Wall, there is no transmural involvement. So inflammatory cells are not present in muscular layer. Typical feature, presence of crypt abscess. That is pus localized within the crypt of the intestine. Now let's take these typical features and look at the histology shown in your Robbins. First, Crohn's disease. So first was ulcer. What kind of ulcer are there? Deep ulcer. So you can see the deep ulcer or fissure right here. Second, the typical feature is non-caseating granuloma. Here is the non-caseating granuloma. Third, there is transmural involvement. That is the complete thickness of the wall is involved. So there are non-caseating granuloma throughout the complete thickness. Next, ulcerative colitis. First, what kind of ulcer are there? Superficial ulcer. So you can see right here, there is superficial ulcer. Second, is there transmural involvement? No. So you can see only up to this much part of the wall is involved. Below that, there is no involvement. Third, what is the typical feature? Presence of crypt abscess. So here's the crypt abscess. What is crypt abscess? There is your crypt which is lined by glandular epithelium, and within the crypt there is localized pus. So localized pus within crypt is crypt abscess. And with that, we are done with Crohn's disease and ulcerative colitis, both gross and microscopy. So if in exam they ask you about Crohn's disease, draw this diagram for gross, draw this diagram for microscopy. If they ask you about ulcerative colitis, draw this diagram for gross, draw this diagram for microscopy. In microscopy, remember 3 points. First, the ulcer, second, the wall, and third, the typical feature. Like in case of Crohn's disease, the ulcer is deep, referred to as fissures. In ulcerative colitis, the ulcer is superficial. In Crohn's disease, the wall, there is transmural involvement, so inflammation throughout. In ulcerative colitis, there is no transmural involvement, so there is no inflammation throughout. Number 3, typical feature. In Crohn's disease, there is presence of non-caseating granuloma, and in ulcerative colitis, there is presence of crypt abscess.